right, thank you. So how many are like me right now and would love a post-lunch nap? You can raise your hand, I do. So let me see, the challenge is to keep you awake through the next 45 minutes. So let's see if that is gonna work or not. So let's go. So to start out about telehealth, and I have a great passion for telehealth because we really have used a lot of this as part of our scaling up of a lot of our programs and doing a lot of training. First, let's sort of level set and talk about what is defining telehealth, because I think a lot of times we use telehealth and telemedicine interchangeably, right? And so when we talk about telehealth, I like this definition from the New England Journal of Medicine that really says it's the delivery of healthcare, but also health education and health information services via remote technologies. A lot of times, what we mean by telemedicine is a part of telehealth, and telemedicine specifically refers to, the way I think about it, is direct patient care, right? So it's basically a provider seeing another patient at the other end remotely and delivering services that way. Whereas telehealth, like teleeducation, teleconsultation, those fall under the telehealth arm, and that's what I'm going to be talking about today for the most part. All right. So how, do you ask, does telehealth fit in implementation science? Right, so I think you could do it in two ways. Telehealth itself can be the innovation that you're implementing, or it could be the strategic tool that you're using to help you implement an intervention. A lot of times you can actually use both to keep sort of for the project that you're thinking about. And so just to recap from what Dr. Altice had sort of mentioned yesterday, regarding the types of implementation strategies that you can use, right? There's discrete and multifaceted. And so with the discrete, obviously it's a single action or process, and then the multifaceted is combining multiple discrete strategies. And you can use telehealth in both, and I'm going to give you some examples. So what am I talking about when we're talking about telehealth implementation strategies? What are we thinking about? And so what I'm going to talk about mainly today, but I'm going to touch upon some other things as well, is this ECHO and ECHO-like programs. Now, how many people here are familiar with ECHO when we say ECHO? Can you raise your hand when I say ECHO? Okay, so one person, yay, that's great. But I'll go into a little bit more detail about what ECHO is. But ECHO as a program can be used for clinical, but it could also be used for non-clinical. We've used it for quality improvement in Jamaica, for HIV quality improvement. It can be used for programmatic, it could be used skills sharing, healthcare training. And so it really has a lot of uses. And so ECHO specifically started out as clinical, but as it scaled up across the world, and let me talk a little bit more about that, it really started to be used for other purposes, which is why I put down ECHO-like. Then there's web-based asynchronous online assessments or interventions. I'm going to give you two really sort of good examples of how that was used, particularly when COVID hit, and so I'll get to that as well. But for instance, these particular intervention was used to do a focus group as well as to do photo voice as well, which I'll get to. But there are virtual coaching calls, right? I think these were really innovative pre-COVID, but post-COVID, I think if you've got family members and you're on like your cousin's sort of WhatsApp or FaceTime, most of us are doing coaching calls with our cousins or having a breakdown and so forth. I think we've gotten used to doing this, but using the virtual coaching calls, really you can do the same thing by supporting clinical work, you can support QI work, and as well programmatic and administrative support. And then there's a telemedicine piece that you can use specifically to be able to scale up. And then you can use this multifaceted strategies that could include, as part of the multifaceted strategies, telehealth interventions. And I'm going to touch upon the learning collaborative that I'm involved in as well, specifically in scaling up HIV PrEP in the US. All right, so then how does that fit in? So I talked to you here about the telehealth strategies, right? And then you know about the discrete versus multifaceted strategies in implementation science. And you heard about this as well from Dr. Davis this morning and Dr. Altice yesterday about the ERIC discrete strategy compilation. And so what I just did, just to give you a sense, I looked through all these 73 compiled discrete strategies, and I thought, all right, how many of these could I use Echo for, Echo-like programs? And you can see here there's a huge list of these strategies and implementation science that you could sort of apply Echo and Echo-like programs for. From building a coalition, to sharing local knowledge, to conducting educational meetings and ongoing trainings, and providing clinical supervision and consultation. Similarly with the virtual coaching calls, and those you can do individually, you could do locally, you could do regionally, you could do nationally, right? So you can sort of figure out how you can do that reach, and almost similar, you can use any of these strategies using the virtual coaching calls. The web-based interventions, like I said, and this was really quite effective, the assessing for readiness and identifying barriers and facilitators. So this was, the example I'm going to give you was doing a focus group through web-based during COVID to really inform how to implement Echo in Malaysia. And then the other big one, which you keep talking about, right? We've got to involve patients and consumers and family members in any project that we do, right? Otherwise, it's just, nothing about them without them, right? Or about us without, without us. We have to have that input for any type of successful programming that we want to do. And so again, there was the photo voice that was during COVID ended up being done through web-based intervention. Then, of course, with telemedicine, you can use it in various ways, as well as the multifaceted strategies that I'm going to talk about in terms of the learning collaborative. All right, so let's talk about Echo and Echo-like programs. So what is it, right? So the origins of Echo really started with this brilliant man, Dr. Sanjeev Arora, out of the University of New Mexico, where he, as a gastroenterologist, really saw that only a handful of people in New Mexico, which is very rural, were making it to Albuquerque to get treated in the specialty clinic for hepatitis C. And so he came up with this idea well before COVID, well before everybody, before Zoom became like a household word, and decided to sort of say, hey, why don't we do this through Zoom? And so, and ended up really having primary care providers out in the rural areas as well as in prisons, video consult through Zoom with experts in Albuquerque at the University of New Mexico, and they created this learning community and the treatment guided sort of consultations that occurred, and showed that the treatment in that way in the rural areas were just as good for hepatitis C as they were at the Albuquerque Specialty Clinic. And this was published in the New England Journal of Medicine. And so this really was a game changer. And you can see here that the Dr. Aurora's mission is for Project Echo is to develop the capacity to safely and effectively treat chronic, common, and complex diseases in rural and underserved areas and to monitor outcomes. And I have to tell you that I work in a lot of urban areas as well, and there are these deserts as well within the urban areas for people to actually access specialty care, even when the specialists are just down the block, for various reasons, right? In terms of people being underserved in the US, being uninsured and underinsured. So here's the New England Journal of Medicine. They published for this Echo model back in 2008. So what this does really is it democratizes healthcare, right? So basically you've got a specialty team, sort of a multidisciplinary specialty team at the hub, and we've got the Echo participants that join in on a regular basis, whether it's weekly, whether it's monthly. These are, let's say, providers in this particular case, let's say for HIV treatment, for hepatitis C treatment. And then these providers present their cases, their patient cases, get feedback from the expert panel, and then they in turn treat their patients locally. And you can imagine how that is a sort of what they call a force multiplier. So instead of, for instance, doing just telemedicine, where a patient will phone in or go see a specialist can see how many patients a day at most, right? I don't know, 10, 15, 20. Whereas with this, you've got the specialist training 10, 15 providers who are seeing their own patients. And all of a sudden, these are 15 providers who are treating 20 or 30 patients of their own. And all of a sudden, you're treating in the hundreds rather than the one-on-one telemedicine. And so, a very simple concept in many ways, but really revolutionary since the age of, since 2008. And so it has really scaled up, and there's now echo programs and echo-like programs around the world, including here in Malaysia. And so with that, you can see here that this has reached almost 6 million echo session attendances over in 200 countries and areas with over 6,700 programs that are out there. And so why use echo as a telehealth intervention? And I think it really lends itself really, really well to both clinical and non-clinical applicability. Obviously, it got scaled up initially in the clinical applicability sort of realm. And in many ways, I'll talk a little bit about my own program in echo that we started back in 2012, but I'm a big proponent of this because I really feel it builds communities of practice. And this is somewhat different, right? You think, okay, so people are joining, they're listening to didactic, listening to cases. Is it like a webinar? And it is far from it being a webinar, right? This idea is that you're creating collaborative learning. You're building a learning community between experts and clinical providers over time. And so basically it can be used for providers, but we've also used it for nursing, you can use it for pharmacists, you can use it for any healthcare worker based on what your mission and vision is in terms of the implementation. But what the hope is there, then you really are elevating all practices to conform around standards of practice and the expectations. So you're ensuring that the quality care is being given even out remotely, whether it's in urban, remote sort of area, like sort of deserts, or whether it's out in remote areas, nationally, internationally, locally, regionally. And this also works, which is brilliant, for high and low volume practices. So for instance, people say, well, wait a minute, I know nothing about HIV. If I join an HIV echo, is that going to be sort of over my head? And other people might say, you know what, I do a lot of HIV work, how is echo going to help me? And both are really great, right, in some ways, because you need to know nothing about HIV or any of the talking that you're doing, and by just coming in on a regular basis, you end up learning from the cases, you end up gaining confidence within that, and then you don't have to do a lot of research. So let's say you are out in the rural area, you've only got 5 patients with HIV. These patients with HIV really can't sort of travel the hundreds of miles to get to a specialist. This particular individual can treat these patients through an echo-like program without necessarily having to do so much extra work in terms of learning about HIV. Whereas let's say you have a new provider starting out and all of a sudden is in an urban area with high rates of HIV and saying, what do I do with this? And all of a sudden their learning curve through echo really is very, very steep because they've got a lot of patients and they become experts in a very short period of time. And it really connects providers with a panel of expert faculty. You create this sort of learning and respect and trust between the two, and you've got that quick access. It improves the specialty care, as we said, and as I sort of mentioned, this is a force multiplier. But for the non-clinical applicability, we use it to train and support non-clinical healthcare team members. So we've done it to sort of scale up community health workers, peers, case managers, and others, particularly in sort of the realm of outreach workers and case managers who are dealing with, let's say, substance use disorders out in the community, and you've got to sort of scale up their training. We've used it in quality improvement and supporting quality improvement in areas where you have sort of to do. So basically, we're supporting quality improvement in Jamaica through ECHO for scaling up their HIV treatment and improving viral load suppression. And then you can use it for both operational and administrative training and support as well. So all right, so I told you the why, it's really quite interesting. How would you do that? If you wanted to go about starting an ECHO, what are the nuts and bolts of doing this, the how to? So you've got to do some pre-work for it. So you want to identify the needs, right? So you find it within your community, what are the needs of the community? You want to take stock of what your internal and what your local resources are, so what you already have access to, and then you want to be able to present the gaps that are remaining to be able to close that gap and improve care. And so then you want to take that data and get your leadership buy-in, your participant, the buy-in there. So as an example, you can sort of say, look, in this area that I'm working in, there's high rates of HIV transmission, particularly among MSM and trans women and people who inject drugs. We don't have enough people and enough access for these patients to sort of come in. We have X number of people in our clinic, and there's so much more out in the community that are not engaged in care. And we have maybe one provider who's comfortable doing HIV, but we have some other providers who are interested in really scale up both for patient access, but also for the expertise within our clinic to do this. And the solution is ECHO, right? So all of a sudden you've presented all this to your leadership. And then, obviously, if you can find funding opportunities, that always makes things easier, right? Money always makes things easier. And so if you can, for instance, for us right now, there's huge focus in the US about ending the HIV epidemic, lots of money being poured into the CDC to scale up HIV prevention, and there's also lots of money in the opioid crisis and scaling up treatment for that. And so you could find pockets to be able to scale up such programs. And then you want to know what your state and federal policies are, right? So if you're going to train, let's say, nurse practitioners or physician assistants, and you realize that they cannot independently treat hepatitis C, then what are you doing, right? So you got to know what the issues there are. For instance, we had restrictions initially when we started doing hepatitis C that it had to be prescribed by either a GI doc or an ID doc. And here we were trying to sort of scale it up among primary care. And so what we ended up doing, we said, well, you know what? We spoke to the powers that be. We said an ECHO is like a consultation with a specialist, and we were able to use the ECHO as a consultation for people with primary care. We were able to scale up hepatitis C that way. So what are the components of a successful ECHO? You really got to think about who your expert faculty are, right? Ideally, if you can do it multidisciplinary, that's great, because people are not a disease, right? They have multifacets to them when they walk in through your doors, whether it's social issues, mental health issues, whether it's HIV and substance use and hepatitis C or so. And so you've got to make sure that you've got a faculty that can speak to all those aspects of it. And making sure that the faculty that are sitting there are consistent. Right? The consistency of your participants seeing the faculty over and over again really creates that bond and that comfort level and the rapport, and does foster that trust. And it has to be not we are the gods in this faculty and you listen to us, right? That is never the case, right? So if you've got an expert faculty member but really has a complex issue of everything I say is right, maybe they're not the right person to actually sit on this faculty and really sort of foster a learning sort of community and a safe environment for them. And so you need to have these sessions being collaborative and engaging, right? We try to make it as case-based as possible. We love cases. Cases, sort of like make people sort of more interested in it. They can sort of really relate to the cases. And it's like a consultation, right? So if you've got a case that you need to sort of guidance on, you can present this case, get the consultants to tell you how to do this, and everybody else is learning along with you. But we also developed a curriculum that we want to ensure that we are going to impart to everybody who is engaged in the ECHO. And so you want to make sure that that didactic curriculum is fairly flexible and meets the needs of the participants for that. So really it's much more than the webinar consultation, and that needs to be understood that way. And then, of course, if you need internet and you don't have internet, you can't have ECHO. And so you've got to ensure that whoever's going to participate in really are going to have access to internet and the ability to connect. We heard over and over again today and yesterday, you've got to have that looped feedback, right? You've got to keep these ECHO sessions relevant, otherwise people are just not going to be interested in doing that. So you want to be able to find ways to elicit that feedback on an ongoing basis, and then adjust your approaches and your content to keep people engaged. And this is key. Having an ECHO coordinator is key, right? Because as I can speak for myself, as a doctor, sometimes I don't know whether I'm coming or going. And so you need to have somebody there really pushing this along and ensuring that it's being coordinated in a way that is efficient and effective. And so for the participants who are going to join, obviously you need their senior leadership commitment to allow them to be blocked and not to be seeing patients, let's say doing their work, during the period of time that they're going to be engaging in the ECHO. And so you also want to make sure that you have a participant buy-in. I remember that we got a sort of a grant from the Delaware Ministry of Health to engage health sort of clinics and methadone clinics in opioid use disorder treatment and scaling up buprenorphine. And so all these participants were being forced to come in. Their they're coming in from methadone, we were talking about buprenorphine, and it was a disaster. Like, we were just there and they were down here and it just didn't work, right? So you've got to make sure that the participants have got the buy-in in terms of what it is that you're offering them. They have to have access to technology, as I said, but you also have to think about the frequency of the echo sessions. Are you doing it weekly, bi-weekly, monthly? Or how long are the sessions? We all started with 2-hour sessions initially, which was what Dr. Aurora had done. We realized who can sit for 2 hours and listen, right? You know, and keep engaged. So then we shortened it down to an hour and a half, and now for the most part, most of these sessions are 60 minutes. We said have that coordinator, because a lot of the times people say, yes, I'm going to do this, and then they're not blocked. So they've got patients blocked during the hour of echo, and they just can't make it. So you've got to make sure that you've got people sort of coordinating that. And active participation, right? It's hard to know whether somebody who's joining the echo and passively just listening, how much are they getting out of it compared to somebody who's actually presenting a case, asking a question, really, and sort of coordinating with that, because that engages the individual much more, and it keeps